This video shows you how to do pre-procedure CT planning using the Redo TAV app. For index TAV is Allegra, and second TAV is SAPIEN 3 or MyVal. When you click Redo TAV CT planning on the home screen, first you will get the overview of all steps you need to do. The CT acquisition protocol can be the same with routine pre-TAV assessment. It's recommended to obtain an ECG-gated multiphasic function CT that covers the entire cardiac cycle, with ideally 20 phases, a minimum of 10 phases. The mid-diastolic phase generally has fewer artifacts, allowing for better assessment of the process's reflex and commission alignment in most patients. The end systolic or end diastolic phases could be used as alternatives. The first step is index TAV and measurement. If a pre-index TAV CT data is available, select nasal valve morphology and the severity of calcification, and identify your patient index TAV type and size. And then you will get the fundamental information of the valve. Please keep in mind that this light blue eye mark is a link to some detailed information. The reflex levels of Allegra is node, counting from inflow to outflow. The leaflet of Allegra starts at node 3 and end up at the node 5. On the next page, select the index TAV failure mechanism and assess commission alignment. Open your patient CT dataset on a CT software. You can use any CT software. We just need 3D MPR, multiplanar reconstruction module. Now we are at 0% cardiac phase, which is end systolic, and move to the diastolic. Now we are around the mid-diastolic. So choose the best cardiac phase with best artifact. So I will choose the 70% for this case. And now at this mid-diastolic phase, you can also see the leaflet clearly. And assess commission alignment, which refers to the relation between the native aortic valve commissure and THP commissure tab. The commissure offset is directly measured using an angle tool with the limit aligned with the native commissure of the RCC and LCC and the THP commissure. In this case, the angle is 47 degrees, so select severely misaligned, and perform the measurement of area and perimeter. These measurements will be used for second tab sizing later. We can also understand how much the index tab is underexpanded at this point. For Allegra, 4 levels require assessment, from node 5 to node 2. So now, make sure the MPR is aligned to be orthogonal to the valve. Bring the plane to the node 5 and measure the area by tracing the center of the stent frame. Down the window level is helpful to see the stent frame clearly. Now you can get the area and the perimeter at node 5 and bring to the plane at the node 4. Do the same measurement for this level. Get the measurement, get the area and perimeter, and bring to the node 3. Do the same measurement by tracing the center of the center frame. This is because less blooming artifact. And adjust the tracing if needed. And lastly, note 2. After or during the measurement, please fill in the areas and the perimeter you measure in the app. Step 2 is identify your patient's coronary risk claim, which is defined as the lowest level of coronaries in relation to the node of Allegra. On the CT, we are now at the outflow level. So scroll down the plane, and now you can see the bottom of RCA, align the MPL, and identify the relative relation with the node. So here, the bottom of RCA is at 0, 1, 2, 3, 4 node, just above node 4. And next, the LCA. Align the MPL to the LCA and identify the relation with the node. So here is at 0, 1, 2, 3, 4, 5. So just above the node 4. So in the app, the bottom of RCA and LCA set the node 4. And the app will automatically identify the coronary risk claim. At the step 3, once you select a second tab, you will get an idea about ideal or acceptable level of neoscat blend, NSB, which is defined as the top of the neoscat. For MyVal or SAPIEN 3 in Allegra, it is a multiple level between node 5 to node 4. This is because the leaflet nadir of Allegra starts at node 3. So to treat degenerated leaflet, we need to implant at least node 4. But as you can see here, at this implant position, we admit some degree of leaflet overhang. If we implant higher, like node 5, there will be almost 0 degree of leaflet overhang, but it can increase the risk of coronary obstruction. Based on such understanding, you will choose neoscat plane, where you'd like to implant. Here is some guide how to proceed from here. We would recommend to assess at all possible neoscat plane and save the summary report for each level. As second tab size and the coronary risk may change according to the neoscat plane. The lowest neoscat plane, which is node 3 for Allegra, should be used only for pure aortic regurgitation, since at this implant position, a second tab will not pin out the index tab at all. Last but not least, when the reason for Redo TAV is paravalvular leakage, please make sure the second tab will cover the annulus level. So, I would start with node 5. The neoscat plane at node 5 will be above the coronary risk plane, both coronaries in this case. So we need further coronary assessment. But remember that a balloon expandable second tab can expand the index tab, which means reduce valve to aorta distance, increasing coronary risk. So we need to determine the second tab size first. Step 5 is in vivo CT sizing for MyVal or SAPIEN 3 in Allegra combination, using the average area at the neoscat plane you chose and 2 nodes below is recommended so far. We already measured the areas and the perimeters at step 1. On the app, the 3 levels will be automatically selected, so please make sure the numbers are correct, and if you'd like to, check the button of Include Perimeter and click the Calculate. Then you will get calculated average area, perimeter, area derived diameter, perimeter derived diameter. The app cannot suggest sizing at this point due to the FDA regulation, so you will need to choose the second TAV size based on your CT measurement. Here has some guide how to choose size, and here you can get the IFU table too. For this case, I will choose size 26 SAPIEN 3 and move to coronary risk assessment with the size you chose. As I mentioned, SAPIEN 3 or MyVal is a balloon expandable valve and can expand the index TAV further. So we would recommend to draw the virtual circle over the size you chose for the second TAV and measure VTA distance from the virtual circle of index TAV stent frame, whichever is outer, and identify the narrowest VTA distance in the zone from the nose-cut plane to the coronaries. When the nose-cut plane is above the SC junction, please don't forget to assess VTSJ. In the app, the relationship between the nose-cut plane and each coronary is automatically identified. When the nose-cut plane is above RCA or LCA, the next assessment is the relation between the nose-cut plane and SC junction. I will recommend to assess RCA and LCA separately and fill in the app. Let's start with RCA. So first, bring up the plane to the nose-cut plane, node 5, and align the MPR to the RCA side, and identify the relation with the STJ. Now, as you can see here, the node 5 is above the ST junction, and here is just at the ST junction level. So we need to measure the VTSJ at this level with the virtual circle of the size you chose for the second TAV. And as you can see here, the VTSJ for this case is almost 0. So fill in the VTSJ at 0 and scroll down. Now VT erotic sinus. Now the virtual circle is outer than the index TAV, so measure the VT AOS from the virtual circle. And scroll down to the coronary. Now we are measuring the VTC. Although the VTC is 2.2, but the narrowest VTA is at the VTSJ, which is 0. So high risk to sinus sequestration. The next is LCA. So again, bring the plane back to the node 5 and then assess the relation with the ST junction first. Again, for this side, the node 5 nose-cut plane is above the ST junction, and here it's just at the ST junction level. So assess the VTSJ and which is at 0 millimeter. Scroll down. Now, for this case, VTLOS is almost the same with the VTC. So I will skip the VTLOS measurement, just do the VTC. But again, even though the narrowest VTA for LCS side is at the VTSJ, which is 0. So for this case, the nose-cut plane at node 5, the narrowest VTA for both coronary is 0 and high risk to coronary sinus sequestration. Then you will get summary reports of 3 pages which include animation representing the relationship between the neoscatogram and both coronaries. You can take screenshots and also import these reports into CT software summary report, such as 3 So, next, let's assess the different neoscatogram level. You will come back to the step 4. Choose neoscatogram and select node 4. The neoscatogram at node 4 will be below the coronary risk plane, and the risk to coronary is considered as low. Step 5 is in vivo CT sighting. Do the same steps with before. Now we select node 4. The app will automatically select node 4 to 2. Make sure the value and get the average area. Now you notice that the average area is smaller than that for node 5. And now, based on the IFU table, I would choose site 23, SAPIEN 3 for this case. As I mentioned, the neoscat plane at node 4 will be below the coronary risk plane, post-coronary. So no need further risk assessment by PTA distance. So the neoscat plane at node 4 is below the both coronary, so risk to coronary is considered as low. You will get the summary report of 3 pages. If available, the information of pre-indexed TAV CT can be gathered at step 8. This information can help your planning more. Based on all information and your analysis, please consider the feasibility of Redo TAV for this patient and which neoscat plane is more suitable for your patient. I hope this video help your planning. Thank you.